Well, welcome, EMS research enthusiasts, to the February 2018 PCRF Journal Club. As you all know, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Tony Fernandez, Sean Britton, Dr. Bill Toon remotely out on the ambulance, and David Page, fresh off the fantastic research summit that just happened this weekend in Minneapolis. We're also joined by two of the study authors, Dr. Asimos and Dr. Dozois. So welcome, Dr. Dozois and Dr. Asimos. The study we'll be reviewing today is entitled PLUMBER Study, Prevalence of Large Vessel Occlusion Strokes in Mecklenburg County Emergency Response. And this was published in the journal Stroke in 2017. Now, as usual, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World called The Trip Report, Turning Research into Practice. We encourage listeners to check out this article. We'd also like to remind our listeners about an upcoming deadline for new abstracts. This is both educational and clinical abstracts. This is for the 2018 National Association for EMS Educators Symposium and also for the EMS Expo International Scientific Symposium, which this deadline will be on April 30th, 2018. So we will be sure to provide monthly reminders before our podcasts about these exciting opportunities for budding researchers, but mark your calendars. April 30th, 2018 is the deadline for both educational and clinical abstracts. So thank you all for joining us today. So let's jump in. And we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. So this study, the PLUMBER study, just a little bit of background. Acute stroke, we know, is suspected when patients exhibit a sudden onset of neurologic deficit that's focal neurologic deficit, and that can be explained by a vascular cause. We also have a belief that patients with suspected acute stroke should be triaged with the same priority as serious trauma or acute myocardial infarction, really regardless of the severity of the deficit. We have standard treatments that we know, routine airway, breathing, and circulation assessments, supplemental oxygen only as needed, checking a blood sugar, and performing a validated stroke severity scale examination, which is a topic for another time, but wow, all these stroke scales, and that might come up today as well. IV access, and very importantly, obtaining the last known normal time or last known well time of the patient. Then pre-hospital notification and transport to the closest appropriate certified stroke facility. Well, one of the areas of intense investigation is trying to determine the ideal destination for patients in the field with suspected large vessel occlusion. And the therapies of endovascular therapies that can be implemented at certain comprehensive stroke centers just aren't available at every stroke center. So this network of stroke treatment has become more and more complex, as the authors point out in the background of their article. But so their goal was to determine the prevalence of large vessel occlusion in their own county's EMS population as screened for stroke. And I'd like to actually ask Dr. Dozois if you could just give us the background of why this was important and what led you to want to look at the prevalence in particular of large vessel occlusion in your EMS population.
Of course, yeah. Thank you so much for having us, Megan. And I'll speak a little bit more to that. You did give a really great introduction to some of the active areas of research in pre-hospital stroke care right now. But again, to highlight the importance of triaging patients with suspected large vessel occlusion strokes. This all kind of stemmed from a couple of papers, now multiple papers that have come out since in the last several years or so, since 2015 mainly, that have shown that patients with these ischemic strokes that are due to some sort of occlusion in one of the large vessels, the large intracranial vessels, do better at centers that are capable of endovascular therapies. So those are typically your comprehensive stroke centers. So since that was determined, there's now been this big push to identify which patients are those that benefit from this therapy, which patients are the ones that have the large vessel occlusions. And that's because, while ideally, while there are many of these centers that can perform endovascular therapies, that they aren't every single center that can potentially take care of stroke patients. So the idea of potentially triaging all stroke patients to centers that are capable of endovascular therapy just isn't exactly something that's feasible. Now, about 50% of people do live within 1 hour of a hospital that's capable of endovascular therapy. So it's really important to identify those patients that can potentially benefit from those types of treatments. And so in response to that, there have been a variety of different scores and scales that have been determined to try to identify patients that have large vessel occlusions. Some of those are the LAMS, or the LA Motor Score, or the RACE, which is, I think it's rapid evaluation for arterial occlusion. This is in addition to some of your traditional stroke screens, which are essentially screening tools that EMS providers can use to determine if they think a patient is having a stroke. The most common one, and the one that we used in this study, is the Cincinnati Pre-Hospital Stroke Scale. Now, the way that these two ideas, identifying patients that have an acute stroke and identifying patients that have a large vessel occlusion, the way that those two ideas go together was really highlighted by an algorithm that was published in 2017 in Stroke. So this is an algorithm that was designed to try to help pre-hospital providers triage patients with an acute stroke, and triage patients that they think might be having a large vessel occlusion. The recommendations there are to use a stroke screening tool, such as the pre-hospital stroke screen. If a patient is positive for that, then they would kind of be included in the rest of the algorithm. If they were negative for the Cincinnati pre-hospital stroke screen, then they would be excluded from the algorithm, and stroke would kind of be taken off of the table for those patients. So once that if the Cincinnati or the other pre-hospital stroke screen was positive, then they would employ the stroke severity score, so something to look for large vessel occlusions. And if that was positive, then the recommendation would be to take a patient to an endovascular center. Now, that is really what kind of inspired us to do this study, in that, our concern is that we don't really know how common these large vessel occlusion strokes are throughout the population. So if, that really impacts the prevalence of disease, really impacts the performance of these severity scores. So if the prevalence of disease is low, then there's going to be a very low specificity, low sensitivity, leading to a low positive predictive value for these scores. However, yep, if the prevalence is high, then the positive predictive value will be much higher. And we can go into that a little bit in greater detail later. So that prevalence feature was something that we felt like was missing from these algorithms, something that really needed to be answered.
Now, can you just take one moment before you go further and describe for anybody who might be just a student out there, prevalence versus incidence, because we commonly hear people use those two and they're very different. Can you describe why prevalence is important?
Yeah, so the prevalence of disease is really, at a certain snapshot in time, the number of cases that you'll find. So when we talk about the prevalence of disease, we talk about, how many events there are of a pool that you're looking at. So, for example, in our study, we took our population as all of patients who were transported by EMS. And the prevalence of disease is the number of large vessel occlusion strokes within that population.
Okay. So because these are both common terms in epidemiology. So we'll hear, some people use them interchangeably, and we want to know why, why one's used versus another.
I see. And so, right, to elaborate a little bit, the incidence kind of is more related to the risk of contracting a disease. Yeah. So, it is essentially kind of, and it sometimes can be thought of as, in general, what your risk is kind of going forward, whereas the prevalence is sort of a snapshot in time.
Yeah. Okay, great. Thank you. Okay, sorry to interrupt your flow.
Of course, no. Do you have any other kind of comments on thoughts that you were having when we were developing the study and when we were going forward with it?
Yeah. Well, you talk about. I'm sorry. Go ahead, Bill. Did you have something?
This is actually Dr. Asimos.
Oh, Dr.
And just to provide a little bit more background, yeah, the main reason we started this was we know there are these stroke screens, these stroke severity screens out there that, to a large extent, have relatively poor specificities. And the question is, or the concern is, if you take a bunch of screens with poor specificities and apply them to a population where the prevalence of disease is low, the potential for over triage, especially in this scenario, is going to be significant. And there's really no data that it had looked at what is the prevalence of large vessel occlusion stroke in this population that this stroke severity triage and destination algorithm applies to. So that was really, the big question that we needed to sort out, because we know that not only are you going to have patients with ischemic strokes, you're going to have stroke mimics, you're going to have lots of other things other than large vessel occlusion strokes in the population screened. So it was important to do that, and really nobody had published that in looking specifically at an EMS population.
Okay.
And Megan, this is Dave. I think it's important here to just kind of revisit sensitivity, specificity.
Yes.
Just to kind of keep our novice researchers, and I think one of the goals of the PCRF is to just make research more understandable and accessible. And when specificity and sensitivity get tossed around, I think we need to just go back to do that. So anyone want to take a stab at explaining it?
Well, I think Dr. Asimos just mentioned that when we're talking about mimics, we're talking about looking at the entire population, and specificity would be if the stroke scale actually, or stroke screening tool, whatever you're looking at, is able to identify stroke in the larger group of patients versus the other mimics. And sensitivity would be anytime you actually identify a stroke using that stroke scale, how often does that stroke scale pick it out, or what your percentage. So some of these, and this is sort of my issue with stroke scales, and that is that I'm not sure that EMS providers are using them to actually say, is this a stroke? I actually think that EMS providers, the suspicion of stroke, the clinical suspicion of stroke, comes from a variety of pieces of information. Number one is the history of what happened, the sudden onset of a neurologic deficit, a focal neurologic deficit, and the risk factors of atrial fibrillation or chronic hypertension, actually before that, atrial fibrillation and prior stroke. So I think when that comes together, then the tool might be used to verify, confirm, or deny. And then, when you have all of these other mimics in there, that's when we get into a different field.
Yeah, I love it, and I think that I always like, because we have paramedic students from all over the country and possibly the world. Actually, we have some international guests also logged in. I always want to liken it to something like STEMIs, where a 12-lead EKG is sort of widely accepted as a tool that if you identify it and the algorithm on the computer says that's a STEMI, then it's highly specific. It's really gonna when it says it, it's gonna be specifically finding things, right? But there's many MIs and and some STEMIs that are not caught by that computer or that 12 lead. And so it's not as sensitive as we would want it. So if you have high sensitivity and high specificity, then that's the kind of gold standard for, okay, we have a test that will for sure give us the pre-alert that this is really a stroke. And that's when we want to try not to overreact, because we're activating, whether it's a cath lab or either a STEMI center, trauma center, in this case a stroke center. We don't want to have all of those resources at the ready if in fact we're faking it. We're calling something that isn't that, and that's the issue. How much are we going to cry wolf?
I think that's a great example, though, David, and I think it's a great example because, like you said, not all 12 leads are going to pick up something. And if somebody says, I have an elephant sitting on my chest, and they have, a zipper scar down their chest, and they've had a prior MI, I sort of don't care what the 12 lead says. So that's sometimes I think we're not getting at is what is in the mind of the EMS provider. What are they using the tool for, and what are we, what are we getting at out of the tool? And then the whole idea of, is this like, when we use trauma as an example of what we're headed for, then we know there's going to be an over triage rate, because there is with trauma centers. So one of the articles I know that that some of us worked on was the paramedic perspectives on barriers to acute stroke recognition. And out of that, we looked at focus groups and kind of try to tease apart some of the actual EMS experience of trying to identify stroke, and came up with patient-related factors and system-related factors. The dominant patient-related factor was communication and complexity. So the communication might have been a language difference, and the other was the complexity of the patient presentation. Like in terms of the mimics, sepsis was a big one. Because the prior stroke history and new onset of infection clouded the ability to determine whether it was new, so they just kind of overcalled it. And then the biggest system-related factor by far was the lack of feedback. So you take a patient in, you never know what happens, and you see an article published that you're not very good at identifying stroke. Well, it'd be great if we knew that in real time. So I think that was that's another piece of this identification of stroke using stroke scales.
Mm-hmm.
And if I could just
go ahead, Dr. Asimos.
I was just going to make one other important point, because I think it's crucial to understand the patient population that we started with. So, for example, just like you wouldn't do a 12-lead EKG on every patient that EMS transported, who do EMS providers do 12-lead EKGs on? They're patients who they're concerned may be having an acute coronary syndrome. So in our study, from a prevalence of disease, we didn't really determine the prevalence of disease in all patients transported by paramedics. We evaluated the prevalence of disease in the population that's either dispatched as a suspected stroke, or the paramedic providers arrive at the scene and are concerned that the patient's having a stroke. And that's an important, it's important to understand what the starting point is. And the reason we chose that as the starting point is, again, if you go back to the algorithm that has been produced by the American Stroke Association, Heart Association, that's the population that their algorithm starts with. It's not, every patient provided with or transported by EMS. So that's why we specifically started in that patient population.
Right. And also, it's sort of more practical from from an implementation standpoint, and how would this potentially change practice? I don't think that we'd ever be at a point where every single patient, would be necessarily screened for stroke or considered for transport to an endovascular center. But it's in those patients that you have a reason to consider stroke, and that's kind of at the discretion of the EMS providers that we worked with.
Great. And when you said prevalence in the population, also just dispatched as a stroke, and not just EMS identified as a stroke, but you didn't use like EMS use of a stroke scale. You used EMS, put that on their chart that this is my final, word that I think this patient's having a stroke.
Right. So it was either they were dispatched as a stroke, or if they were dispatched as something else, they could have gotten to our study because the EMS providers thought that it was potentially a stroke.
Okay.
Right, and we did, and there's some data that we actually didn't publish in this paper. Our so within our stroke EMS protocol, the protocol says that they should apply a Cincinnati pre-hospital stroke screen to all patients. We know that not all the patients that were enrolled had that screen performed. What we also don't know is how much the results of that screen may have, in the patients in which it was performed, led to the diagnostic suspicion that the patient, you know, was having a stroke or was not having a stroke. So, you know, that's somewhat of a limitation.
Yeah.
We don't ultimately know the reasoning that led to the paramedics' diagnostic conclusion of a suspected stroke.
That's good. That's a really good point. Really fascinating.
Congratulations. Yeah.
So.
Yeah, very nice work. You know, in your methods on the study population, one of the things you mentioned is that the dispatchers assign a dispatch code to this, and I wonder how much you kind of dove into the concept that the pre-alert from the dispatcher to the crew is or is not used, and improves or doesn't the ability of the crew and the final answer to be actually predicted. That there was a very nice abstract presented at PCRF by the medical priority dispatch folks that do this algorithm, indicating the dispatchers were actually better at calling strokes than the crews were. So had we listened to the dispatchers more carefully, we would have actually been better at determining who had a stroke. I'm wondering if you followed up on that at all.
Yeah, well, so we actually we did in our initial manuscript. Again, it was sort of cut in the final manuscript that was submitted to stroke. We reported the incidence or the prevalence of stroke among patients who were actually dispatched as a stroke, and among patients who medic, you know, were considered as a possible stroke. And in our study, contrary to, you know, the abstract that you were just telling us about, our paramedics here were actually much better at determining who had an acute stroke than the dispatchers were, you know, which is what I would expect, given that they're kind of they're in front of the patient. They can kind of use these tools. They can use these screening tools as well. You know, I think in our study, you know, the majority of our patients came into the study as well because they were dispatched as a possible stroke. So about 72% of the population, or I'm sorry, 80% of the population in total was dispatched as a possible stroke.
So do you think that if they get sent to a stroke, that sort of pre-alert or predisposition, or the hint, the subliminal context to which you're going, assists in the recognition, or does it over triage itself?
I think that that's definitely a possibility. I think that the extent to which that biases the providers, you know, in a positive, you know, using that as either a positive or negative thing, you know, I think that that's something that's really hard to determine from a retrospective study. You know, but you know, I think that's certainly a possibility.
But I think yeah, I was going to say this is a super important point to be discussing, because I think the question is, a lot of people would argue the dispatch, including patients dispatched as a stroke, just is going to add a lot of noise, and all it's going to do is lead to a whole bunch of patients who don't have a large vessel occlusion. And especially, again, when a screen is applied with a poor specificity, it's going to just really enormously increase over triage. So I do think one of the questions is, you know, moving forward, should these algorithms include patients that are dispatched, but yet when the paramedics arrive at the scene, they don't think the patient's in fact having a stroke? I think that's a really important and worthwhile question, you know, just to talk about. And I don't know the answer. Our data would suggest that it mostly adds a lot of noise, but you know, it's certainly... We
have a couple of comments from our participants out here. So sometimes, just for the author's sake, I wanted to let you know that we have a little chat area, and some people can type in questions and comments. And we have a few. We have one from Stephen, who, is there a value in tailoring destination decision based on a sliding stroke scale to help account for the difference in how important sensitivity and specificity is when compared to distance from a thrombectomy capable center. For instance, require a higher race score to justify a longer transport. And then another comment from Chris Boyer on stroke scales. A stroke scale is a piece of the puzzle, and this is, I think, what we were just talking about. I think I completely agree. Too many providers are taught the stroke scale is the sole diagnostic piece in stroke care, and I have to agree with them too, because I know in January of this year in pre-hospital emergency care, there's an article, Cincinnati Pre-Hospital Stroke Scale can identify large vessel occlusion stroke. So I think one of the other things that we're missing here, and I'm really surprised nobody's brought it up yet, is, you know, way back when, we used to communicate a lot with our hospital. We used to have a base hospital. We called the base hospital. We confirmed. We discussed. We, you know, made before we made critical transport decisions. Has there been any discussion? We hear, you know, read a lot about telestroke consultation. We know that large vessel stroke therapies too don't come without first treating with TPA. So I think that's another thing that people may not realize out there is it doesn't delay the administration of TPA initially while they're getting a CT or CT angiography or MR angiography or whatever they use in imaging. So, you know, this whole idea of what I think the neurocritical care calls the drip and ship model, where you start the TPA and you transfer to a higher center that's, you know, capable of these kind of therapies, is one way. And another thing is communication, telecommunication or communication in general to identify prior to. Has any of that come up?
Yeah, well, there's kind of a lot in those questions. So I'll kind of tackle just the first one to start with, you know, whether or not a kind of a sliding stroke scale might be used. And I think that the only thing to remember about that, and it's something that I wanted to also address for, you know, anyone that's kind of learning a little bit more about research in these terms is, you know, when we're talking about, you know, we're weighing the specificity and sensitivity of each of these different scales and how our prevalence fits into that. You know, it's important to remember that, you know, the specificity of the scale is going to really impact your over triage. So if you want to minimize over triage, minimize the patients who don't want to, who don't have a stroke, who are triaged to these centers, you want to really maximize your specificity. Now, sensitivity is going to, you know, impact your under triage. So if you want to, you know, make sure that all of your patients who have a large vessel occlusion stroke are getting to the endovascular center, the comprehensive stroke center, then you really want to maximize your sensitivity. So the rate, you know, something like, you know, the race score that has, you know, you know, has different scores, you know, on a numeric scale. As you sort of push your threshold for transport up a little bit higher, you're going to increase your specificity. So you're going to take down the number of people who don't have a stroke who are potentially going to this this comprehensive stroke center, but you're going to lose a little bit of your sensitivity. And I think that, you know, one of our big points for discussion is that, you know, we as a community haven't really agreed on where we want to draw that line in terms of how many patients with a stroke, with a large vessel occlusion stroke, do we want to miss in order to maximize triage of the appropriate patients? You know, so I think that that's just something to remember there. And, you know, what you were saying about kind of the drip and trip model is something that is, you know, I think that that's what we rely upon a lot of the times too, to remember that even if we're wrong, even if we don't transport a patient who has a large vessel occlusion stroke to the endovascular center initially, then they'll still get a treatment on the way to definitive therapy.
Yeah, and I think you're hitting it too. One of the things I think is frustrating, and this kind of came out in Chris's comment, is that stroke scales are not necessarily made for identification, but for severity and trending. You know, trending is probably the most important thing. That's the NIH stroke scale was not so that you determine whether or not a person was having a stroke. I think that, again, comes from the clinical suspicion of the presentation and the history, and then the you know, presence or absence of hemorrhage from an image will tell you which type, and you know, and other masses or anything else. But they're for severity determination and trending of that severity with treatment and time. So I think it's interesting that we've made them this kind of, are they having a stroke or not? I mean, to me, if someone's applying a stroke scale, they have some suspicion to begin with. So yeah, it just automatically makes the their noise in the data.
Yeah, and we did, although we've moved into this era of these stroke severity scores where it's not a binary, either the screen is positive or negative, it's what is the actual score. We did initially start with these stroke identification screens like the Cincinnati pre-hospital stroke screen and the LA pre-hospital stroke screen, which really theoretically were never designed to say how severe is this stroke. It was really to make that diagnostic suspicion of, does this patient have a stroke, yes or no. One of the questions that was asked, and we're getting way ahead of ourselves, but is the Cincinnati pre-hospital stroke screen, how did that perform relative to sensitivity and specificities for large vessel occlusions? And we did look at the population. This isn't in this manuscript, but we did look at how that performed in the patients that had that screen. And remember that I already pointed out that not everybody had that screen, but it did pretty well. I think it had 97% sensitivity and 43% specificity in the patients that it was applied to for identifying large vessel occlusions. So as I think somebody suggested, it from a sensitivity standpoint, it performed pretty well.
We have a comment from Chris Metzger also with the addition of ultrasound, point-of-care ultrasound, and I know there's at least one study I know of that's ongoing with point-of-care ultrasound and stroke. Could this increase specificity of transport decision?
Yeah, and there is, there is a lot happening. I mean, there's, obviously what we're focusing on today are severity-based screens in the hands of EMS providers. There's the mobile stroke unit out there with the combination of CT and frequently telemedicine. There's telemedicine alone, which somebody referenced, and then there's stroke screens provided by EMS providers, and then there's really novel things like ultrasound being applied in the rig. I think there's some concerns with, can you get, what is the adequacy of the bone window, and can you deal with hair and other things that are going to impede the availability of ultrasound? But there are people that are absolutely looking at that. As much as I love ultrasound, my suspicion is that that's not going to emerge as a good way to screen patients. But absolutely, that is something that some people are looking at in the pre-hospital arena to see if
it's fascinating, and I think you bring up a great point in medicine in general, that every expert has to actually redo an assessment and confirm that the previous person found the things that they found. We found this in STEMIs too. You see the ST elevation, you call the STEMI, you get to the ER, and the ER doctor says, oh, well, it's back to baseline, and I don't see the STEMI. So you have to really actually advocate for it. But this is what we saw when we saw it. And then, we were doing a study back in the 80s. We were trying to daisy chain a bunch of cell phones so that we could do a remote transmission, a telemedicine transmission to a neurologist, so that they could see the patient in the back of the ambulance and sort of be reassured that the tests that we were doing were actually significant enough for them to think of, and that at that point, thrombolytics. So it's this concept of we have to have the neurologist actually confirm that the ER physician is really seeing what they're seeing, or that the ER physician is seeing what the paramedic is seeing. And I am just curious about your opinion about that. Is once we see these symptoms, the need to transmit and or have another person confirm them is a pretty big part of how we delay, actually, and have to almost do some really fancy technological steps to have somebody else kind of re-see it.
Yeah, and that happened with an accuracy of first recorded last known normal time of stroke patients. There was a great article on the multiple redefinitions that occur along the way, and not that it was a bad thing, but that it did exactly what you were talking about, David, the whole, starting with the pre-hospital or family, depending upon who brought in the patient to the hospital, and then the redefinition in the ER, and then the redefinition with neurology. So that's something I think it's part of the continuum, correct?
The,
Go ahead, Dr.
The one thing I'll say is, you know, the challenge of stroke is sometimes the presentation is profound, and you know, we get pre-hospital reports of suspected strokes from EMS providers all the time, and you know, when they call in, they say the patient's got a left-sided gaze preference, they're aphasic, and they're not moving their right side. I think everybody, not only the paramedics, but the ED physicians who haven't had the benefit of examining the patient, feel like, wow, that patient's got something going on in their left, you know, cerebral hemisphere, you know, until proven otherwise. The challenge becomes when the presentation isn't classic and it's more subtle. You know, I think that's when it becomes more of a challenge, and that's when the thought is, well, how much value would talking to someone with more expertise have in this case, or better yet, how much value would that physician actually doing an exam while we're transporting this patient add value? So
I think that the value might be that the confusion right now is, okay, do we, I think it's very similar to STEMI versus, you know, do I go to a STEMI center? Is, do I need the 12 lead to tell me that, or or is this person who is definitely presenting what I think to be, is that enough? And that's somewhat training and EMS protocols, but the value is that, what do you want us to do when we get to a skilled nursing facility with someone who's had a prior stroke, has a new onset of neurologic symptoms, an uncertain history, and we you know, could be a stroke, might be sepsis, not really sure, language issue. What do you want us to do? You know, it's sort of like that, you know, do you want to see them at your hospital, or do you want us to just go to the regular, you know, that's kind of when a protocol can't define it. Or hasn't done it well, and maybe that's a training issue.
Yeah, and you know, over triage with the flu epidemic that we're in right now, you know, I'm going to work this evening in the emergency department, and there are going to be patients everywhere. You know, we are so sensitive to over triage right now that the last thing we need is more patients that are routed to our hospital who really don't need to be there. So I think, you know, the flu epidemic and what it's doing to emergency departments is really putting an emphasis on this whole issue of how careful we need to be relative to over triage in things like this.
Boy, that's another show. That's actually definitely another show. So can we have the table up. If you could walk us through the, I don't know if you can see it, but you know your research. So the table, the study flow chart about how you went through and what you came up with. I don't think we really covered that to any great degree because we got sort of into the nitty gritty of stroke scales there for a bit. But we don't want to ignore too that large vessel occlusion is devastating and treatable, and it can commonly happen in young people. And not that, you know, we're being ageist here, but it's a devastating and treatable thing. So many things that have low prevalence are still devastating, and that's something we want to make sure that our listeners understand, that we understand the serious nature of this. So, and how important it is to try to get at providing the best care for these patients. So, if you could walk us through these results, that would be great.
Sure, absolutely. So, you know, this is, I think, the bulk of, you know, what we have to report here. So just going from top to bottom, the top row is really our entire study population. So these were patients who either, again, were dispatched as a possible stroke, or the EMS providers who met the patient considered them to have a stroke. Many patients, as you can see, had both of these things were true. So the dispatcher agreed with the EMS providers that met the patient initially. So between all of those groups, we had 2,400 patients about. And then we broke those down into what their final diagnosis was. And that was determined based on looking at either the ED record or the hospital discharge summary. And we had special kind of trained abstractors who looked at those notes and determined what the patient actually had. So as you can see, you know, there was, you know, quite a bit of noise in our study. About 67% of the patients did not have end up having any diagnosis that was related related to stroke. Now, these other 4 categories here, kind of on the left, are those patients that did have a diagnosis that was related to some cerebral vascular event. And as you can see, patients with an ischemic stroke represented about 20% of our whole population, so 20% of that 2,400. There were a small portion, so 45 patients that did not have a CTA, a CT angiogram, or an MR angiogram. The reason we report that is because we couldn't really determine whether or not those patients had a large vessel occlusion ischemic stroke or not. In the majority of those cases, it was because either there was some contraindication to that study, such as, you know, an elevated creatinine, precluding giving IV contrast, a pacemaker in place that made someone unable to have an MRA, things like that. Or sometimes it would be patients who you know, had such a devastating presentation that the family immediately determined to just go towards comfort-directed care and refused all other interventions. So for the patients who had a CTA or MRA, which was about 90% of the patients who had an ischemic stroke, we found that about 117 patients had a large vessel occlusion. So that 4.8% that's listed there is of our total population, so the 2,400 people. Now, 13% of patients of that 2,400 had an ischemic stroke that was not due to a large vessel occlusion.
Okay. Yeah, Tony, I think you have a question about linking the data and how they link their data.
I do. I wanted to, again, congratulate the authors on the study. I think it's great. And the way I see it, one of the most important things in your study, obviously your results are very important, but how you obtain these data and link them, I think is really impressive. And I wonder if you could speak to that a little bit to let some of the folks on the call understand that it's really not as easy as it sounds, and there's some work that goes into it.
Yes, we had an excellent team among our authors and people that were helping to support us in doing this study. So we were somewhat fortunate in that most of the infrastructure to kind of help us obtain this data was already in place. In our EMS system, we already have mechanisms in place to provide feedback to EMS. So the way that we do that is that on a every 2-week basis, EMS will send stroke program coordinators at the 2 main hospital systems in our county, and that encompasses all of the hospitals within those 2 systems. So the EMS will send our stroke program coordinators at these 2 hospital systems a list of all patients who were either dispatched as a possible stroke, or who had an impression of stroke, or those patients that the EMS providers thought were having a stroke. And that is already being done just to provide feedback to EMS on how many of those patients actually had a stroke, how correct were they in those diagnoses. Now, using that we use that as our population to screen, as we talked about in this study. So and then from there, we had our stroke program coordinators go a little bit of an extra step and just determine and determining, first of all, whether or not there was a large vessel occlusion present. So we had our stroke program coordinators look at the CTA or MRA reports, and then just entering that into a web-based database. So something called REDCap, which is what we use to capture to enter all of our data and capture it.
Yeah, and so Tony, we're fortunate in that this every 2 weeks when we get this list, it has patient identifiers associated with it. So the stroke program coordinators were able to obviously link that with what happened in the hospital. But as Tony points out, one of the real challenges in doing research involving EMS and stroke when you're trying to associate something that happened in the EMS arena with the patient's outcome is, how do you link the pre-hospital records to the hospital records, and that can become really challenging. You can do it with deterministic or probabilistic matching, But in this case, we were lucky in that we had unique identifiers sufficient that doing that link was not an issue. We were able to do a direct link based on that.
Thank you for
that's great.
answering that.
Thanks for that. Yeah, that tells a lot about all the work that you put in before you even dove into the data. I think it's really important to understand that. And can you talk a little bit about the IRB process with linking data and how I guess progressive or understanding they were with what you were trying to accomplish?
Overall, I think our IRB was pretty understanding of our study. I think it helps in that this was sort of a retrospective study. It wasn't really putting any patients at significant harm. Certainly, we did use the patient identification information that was sent out to us by EMS. But once that was received by the people who were actually looking up patient information and entering this data, it was then entered into the REDCap database and considered de-identified at that point for further analysis. So once the data was sort of mined, then it was put into a database and then considered de-identified after that point. So no patient identifiers were actually stored in our study or kept in any database.
And the other thing I'll point out, Adeline referred to it as a retrospective study, and a lot of it depends on how you're going to define it. I mean, this was an observational study. We identified our study question, and then we prospectively collected our data. So every 2 weeks, we would get a new batch of patients, and the program coordinators at their site would work, with those data, and then 2 weeks later we get a new set of patients. So it wasn't, like we retrospectively said, oh, here's 2,400 patients, let's go back and review, their medical records retrospectively. We had, pre-specified data fields and a data dictionary associated with each of them, so that we prospectively collected the data.
That's a great point you bring up too. Again, for those who are thinking of research out there, a data dictionary is an incredible tool. It helps you standardize. It keeps from variability when you're collecting the data, especially when multiple people are collecting the data. So those who are out there listening, a data dictionary, that's a nice one to jot down in your notebook. There's a comment from Kat Lewis just about what we were talking about earlier about the training and feedback. And if Kat, if you could tell me where you're from too, that'd be great. But I can see from Kat Lewis, we do an electronic debriefing for each stroke patient that includes EMS and ED within 48 hours, and it's focused on the NINDS data. So, this is really relevant, how the training occurs and how much we can share among systems about providing that feedback to hopefully lead to an improved process of identification.
Yeah, the feedback process is hugely important. And since we did this study, and I'm a little bit more familiar with this than Adeline is, because I'm the medical director of our stroke network, but we've kind of got a new and improved database that we use now, and we're able to what we do on a weekly basis, we have an automated report that rather than doing it within 24 hours or 48 hours, we just decided that doing it 1 week at a time, where we were able to provide feedback to our EMS liaison on our patients. So that's how we do it now. But the medics love getting the data, and what the feedback we give them when they've transported a patient and they've identified the patient as a stroke, and the patient either gets IV TPA or goes to the endovascular lab, we give them all the time points. We say, here's the door to physician time, here's the door to CT time, here's the door to IR arrival, here's the door to groin puncture, here's the door to revascularization. And they love that feedback because they realize that the whole process started with them, and they can see, wow, I pre-notified the hospital. They went direct to CT, from the EMS bay with this patient. They didn't stop in the ED, which is best practice that most people recognize. And it really reinforces that relationship and the importance. So we find that they really respond favorably to getting all that process data and the outcome data, obviously, also.
Great, thank you for that. It's hugely important, I think, this this concept of communication. Tony, I think you had another question that I think it would be really relevant again for people that are considering research.
Yeah, thanks again for your time. I think one of the things that I really love about your study is you didn't, as you mentioned earlier, you didn't just go back and look at retrospective data. You did some preliminary work, a lot of preliminary work, and we don't often have a chance to discuss power analysis on these podcasts. And I was wondering if you can talk about some of the assumptions that went into your sample size calculation and how you came out with the outcome of 100 the idea of 100 outcomes and the initial prevalence that you assumed.
Yeah, Dr. Asimos, can you helped us a little bit more with that? Can you
yeah. So when we initially did our sample size calculation, we actually did it. One of our secondary analyses or secondary endpoints that, again, unfortunately we had to take out of this paper was the performance of the Cincinnati pre-hospital stroke screen. And so we actually calculated the sample size two different ways. We said that if we wanted to target 100 outcomes, and our pre-test assumption, we had to start with, what do we think the prevalence of disease is going to be, which is a whole other interesting thing, because when we started this, people were saying, oh, the prevalence of disease is going to be 20% or 15%. And I'm sitting there going, well, there's no way it's going to be, 20 and some people were even saying 25 or 30%. I mean, and the first thing I said is, in a hospital population of patients with diagnosed ischemic strokes, we know that the proportion of patients that have a large vessel occlusion in that population is somewhere between 25 and people have said as high as 40%, although I think most folks are backing down from that now. So we knew it wasn't going to be, that high. I mean, we thought that it was going to be 15. Well, actually, we initially thought it was going to be 5%, so we were pretty close. So we said, assuming 5% prevalence of disease, one of the things we said, if we suspect that the sensitivity of Cincinnati pre-hospital stroke screen is going to be 75% and the specificity is going to be 25%, we figured that a sample size of about 1,500 patients would be sufficient to estimate the sensitivity and specificity of the Cincinnati screen with a confidence interval of 10% for detecting a large vessel occlusion stroke. So our one sample size calculation did it that way based on how we thought the Cincinnati pre-hospital stroke screen was going to perform. The other way we did it was we just said, well, if we want to target 100 outcomes and the prevalence of disease we think is going to be 5%, then we need 2,000 patients to enroll in the study. So those are the two ways we calculated our sample size.
And
that's
so
great,
these
thanks.
were.
I think that's real important.
Yeah.
Yeah, thank you for going through that. So any other questions from our other panelists on the methods, the outcomes, the results? Because we'd like to move into what's next. Where do we go from here? Any other questions about that, Bill or Sean or David? I want to say before we move into where we go, just congratulations on this. It's a really important addition to the literature, and then also one of the things we do on here at the Pre-Hospital Care Research Forum and on our podcast is we screen through the authorship to look for who's actually publishing EMS papers, and it's always really nice to see a mixed group of a team. So we see an advanced EMT, we see several physicians, nurse, a paramedic, FTO, I'm assuming an epidemiology, a master's in public health. So that's really great to see a multidisciplinary team working on what is a multidisciplinary team issue. So congratulations on that.
Yeah, we couldn't have done it without any of those people either. So.
I love what you've done. Again, congratulations. And I did have a quick question about funding, and if you,
Oh yes,
this can be touchy, so I don't really want to over expose any deep dark secrets or special projects you've got. But I noticed that you appropriately disclosed that the source of the funding came from Stryker Neurovascular. And we often have people on this podcast who are interested in doing research, but just sometimes don't even know where they might be able to get a little bit of funding or a lot of funding. So was this a grant, or was this something that you sought out specifically from a manufacturer of some equipment that may or may not be useful to this particular piece, or did they fund something else and then they just helped you fund this? Can you tell us a little bit about how you got there?
Yeah, so this is a study that we, had kind of envisioned doing. We planned to do it whether or not we were going to be able to get funding from any other kind of any outside entity. It was helpful to have a little bit of funding, however, to really be able to properly reimburse the time of our statisticians. So to really make sure that our stats were clear and really, really up to the standards for publication in any journal, including stroke. So what we did is, after we kind of designed the study and had our plan in place, we applied for a grant that was available through Stryker. Obviously, as you know, it is an organization that makes has an interest in strokes because they make lots of equipment that are used, particularly in endovascular therapy. So because of that, they want to sponsor studies that are related to stroke projects. So we, submitted an application that included our protocol, and then were granted a modest amount of funding that mostly went towards our statisticians in that.
Yeah, and managing the database, overall. But I think that this is a really important point, because I think a lot of people are hesitant to go after funding when they have an investigator-initiated study. And, a lot of times you're not looking for a ton of money, but you would like to be able to help to pay someone to design and manage your database, and you want to, pay for statistical expertise or maybe some data abstraction. And I would say I've been pretty successful in getting industry to support research. And, the strategy, and I would encourage everybody to do this, especially right now in stroke, is there are a lot of pretty deep pockets in industry right now, especially the manufacturers of the devices that are used for endovascular therapy. So there's Stryker, there's Medtronic, there's Penumbra, and they are interested in supporting research like this because it's important. It's just as important for them to understand what the answers to these questions are as it is to us. So they didn't have any vested interest specifically in what we were going to find, but they knew that this was really important information relative to the creating systems of care related to endovascular therapy. So I would say to all of the researchers out there that are hesitant to peddle their investigator-initiated study to someone, it's easier to do than you realize. Most of these industry places, you can find an online support site where you can submit a protocol, and if it's something that they're interested in and it looks pretty reasonable and manageable, you'd be surprised. A lot of times you can get them to throw some money at it. So definitely worthwhile considering.
Well, great. Thank you, everyone. We're just about out of time. I don't know if anyone has any last-minute additions, but I want to thank Dr. Asimos and Dr. Dozois for joining us. Big congratulations to you for publishing this very important study, and more to come, I hope, and more for us too. to get involved in. And a little follow-up from Kat Lewis, I think, is a good way to finish this. And this is the communication between the emergency department and EMS is greatly improved. It is a trust thing. I'll add it's a patient care thing. And I think we can only get there, as we believe at the Pre-Hospital Care Research Forum, through good, sound evidence basis and good pre-hospital research. So we know the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research, and we will continue to be here monthly to provide you with that opportunity to discuss and learn more about pre-hospital research. If you are interested in providing us with an article or discussing a particular article or joining us at any point in time, you can always email David Page, dpage@emsed. I believe that's .com or .net, David?
.net.
.net. That's not up on the screen, so dpage@emsed.net. Anything to add, David?
Just that it's a pleasure and an honor to have the authors here, and we hope you'll come back. And just a testament to how good you are, we didn't even have a single comment from Bill Toon. That's a first, I think.
Oh, and welcome to Bill Toon's new EMT. He has a brand new EMT out there. Welcome to EMS. We hope you enjoy your shift with Dr. Toon. If you have any trouble, give us a call.
Hopefully I won't scare off. I do have one last question before you hang up.
Sure.
Are you going to change anything based on the results of your study within the system?
So that's a great question. I would say that we are being very careful about implementing a routing protocol, and certainly now the recommendations are to do a little bit more research in this arena. We were glad to hear that. Now that we know the prevalence of disease, what we really want to find out is how well these a severity-based screen performs in our population. So that's what we're doing now. And the important thing we're also looking at the reliability of the screen, which nobody's reported, meaning if there are two paramedics in the truck and they both apply the screen, what's the likelihood that they're both going to arrive at the same final score? So that's what we're doing now, because we think that that's the other crucial thing for us to understand before we implement any changes. But absolutely, we are going to use this because it's going to drive the over and triage and under triage rates that we can anticipate.
Well, that's great. Thank you. And we will continue a discussion also after each of the articles that we discuss about, where do we go from here? Always, where do we go from here? We sort of ran out of time on this one, but thank you very much again for joining us.
Thank you so much for having us. It's our pleasure.
Great job, Megan.
All right, Jennifer, are you on? Oh, I don't know if Jennifer's on, but thank you everyone for joining us, and we'll see you next month.